Welcome to Section 4 of Psychiatry. In this section, we'll be discussing depression and depressive-related disorders. Let's get started. This is our psychiatric overview figure. You can see many of the depressive-related disorders shown under mood disorders right here. Before we get into the disorders, let's take a step back and define mood. So simply put, a mood is an emotional state. So for example, I could be sad or happy depending on the day, and it's quite normal to feel both of these emotions. However, when a patient experiences extreme sadness, then this is referred to as depression, which is a type of mood disorder. Mania can be thought of as extreme happiness and is on the other end of the spectrum of the mood disorders. So we have mania over here and depression over here. And it can be helpful to think of these as kind of like opposites. So in this video, we'll be discussing depression and the various derivatives of these disorders. In the next video, we'll discuss mania. Before we talk about major depressive disorder, we first need to understand some of the symptoms that depressed patients present with. And these can be remembered with the mnemonic SIG-E CAPS. Let's start with the letter S, which stands for sleep disturbances. This can include a history of either hypersomnia or insomnia nearly every day. I is for interests and represents a lack of interest in most or all activities. For example, a person may have previously enjoyed spending time with family or going on bike rides and now finds no pleasure or has no interest in these activities. G is for guilt and is characterized by overwhelming feelings of guilt or worthlessness. Next is E for energy, where there is noticeable fatigue or low energy in the patient. The first letter of CAPS, C, represents an inability to focus or make decisions. A person could present with a feeling of despair because their mind just won't focus in school or certain tasks. Next is A for appetite. Sometimes people with depression overeat while others undereat, and this can obviously impact weight as well. The P in CAPS stands for psychomotor agitation or retardation, and this can be apparent during physical exam or noticed by others. This can include slowing of speech or restless fidgeting associated with a feeling of mental tension. Finally, the second S in the acronym stands for suicidal ideation, and this is characterized by recurrent thoughts of suicide or death. Suicide is an important part of depressive disorders, so let's discuss this in a bit more detail. For step 1, you need to be familiar with some of the suicide risk factors. This can be remembered with the mnemonic sad persons weep. So the S stands for sex. Women are more likely to attempt suicide, but men are more likely to complete suicide. So being male places the patient at a higher risk of mortality. So S for sex. Next is A for age. Young adults and the elderly are at highest risk. D stands for depression, and a history or current episode of depression put patients at risk of suicide. P in persons stands for previous attempt, which is the strongest single factor predictive of completion. Next is E for ethanol use. Drugs and alcohol are an important risk factor in suicide. However, this is referring to drugs in general, so drugs and alcohol are important risk factors in suicide. R stands for rational loss of thinking, which can manifest in the form of psychosis. S is for sickness, which can refer to a psychiatric disorder like bipolar disorder or a general medical illness such as rheumatoid arthritis, which would result in chronic pain, making the patient more likely to commit suicide. O stands for organized plan. N stands for no social support or spouse. This can foster feelings of helplessness and isolation. The second S stands for stated intent. This refers to outwardly expressing one's intention to attempt suicide. Stated intent does not necessarily include forming a plan to complete suicide, but rather is making one's intentions known to others. W stands for weapons, specifically firearms, and this is the most common method of suicide in the US. But again, a prior attempt is the strongest risk factor, so don't get tripped up on these two. The first E stands for employment loss. People who are unemployed may feel hopelessness or useless to society. The second E stands for exemplified by family members. This is getting at the idea that if a family member has completed suicide, then it puts the patient at risk for doing so as well. Finally, P stands for psychiatric hospitalization. So if someone was recently hospitalized in a psychiatric facility, they're more likely to complete suicide. All right, obviously there are quite a few things here to remember. However, if you only take away two things, remember that a prior attempt is the strongest risk factor and that firearms are the most common method of attempting suicide. Okay, now that you understand SIG-E CAPS and suicide risk factors, let's move on to discuss some of the depressive disorders. This is an overview table covering depression and the various subtypes of depression. We'll start with major depressive disorder, or MDD. This disorder is characterized by 5 of the classic depressive symptoms, which last for at least 2 weeks. As we just discussed, the symptoms related to depression can be remembered with the mnemonic SIG-E caps. A required part of the diagnostic criteria for major depressive disorder is the presence of a self-reported depressed mood, or anhedonia, which is defined as a loss of interest or pleasure in most or all activities. First-line treatment for MDD is cognitive behavioral therapy, or CBT, as well as selective serotonin reuptake inhibitors, or SSRIs. Other less common treatment regimens include bupropion, mirtazapine, and serotonin and norepinephrine reuptake inhibitors, or SNRIs. Finally, if a patient is resistant to other forms of treatment, electroconvulsive therapy, or ECT, may be considered. Since we've never discussed ECT, let's briefly talk about it now. The therapy is administered by placing electrodes on the patient's head to induce a seizure while the patient is under general anesthesia. This is a highly effective form of therapy that can be used to treat various psychiatric illnesses, such as treatment-resistant depression, bipolar disorder, major depressive disorder with psychotic symptoms, schizophrenia, schizoaffective disorder, and acute suicidality. It's fast-acting and has no contraindications, so it's safe in both pregnant women and elderly people, and some possible adverse effects of ECT involve headache, disorientation, and partial amnesia, both anterograde and retrograde, which normally resolves within about 6 months. This is an image of ECT. As you can see, the medical team is placing electrodes on the patient's head and are getting ready to induce a seizure. This has been portrayed as a pretty barbaric procedure in many popular films, but it's actually quite benign. The patient is under general anesthesia with a neuromuscular blockade, so the patient basically doesn't move throughout the procedure, and it only lasts for a few moments. All right, now that we've discussed MDD, let's move on to discuss some topics that can be easily confused with this disorder. 3 of the highest yield to be familiar with, and the most commonly tested, are normal sadness, grief, and complicated grief. Let's discuss each of these in a bit more detail. Normal sadness can be confused with depression because they share some of the features. For example, a patient with normal sadness will likely have a depressed mood, and they may also have several of the SIG-E cap symptoms. However, there are 2 key differences. First, the patient will have less than 5 SIG-E cap symptoms. And second, the patient will have no functional impairment. This is a self-limiting condition, so treatment is unnecessary. All right, now let's discuss grief. The important distinction between grief and depression is that it's a normal response that's typically due to the loss of a loved one. This is the most important part of the slide, so remember, grief is typically due to the loss of a loved one. One of the confusing parts about grief is that it shares many of the symptoms with MDD. For example, a patient may experience sadness, insomnia, poor appetite, weight loss, or others. In fact, a patient with grief may even have 5 or more SIG-E cap symptoms. And if this is present, then the patient will have grief and concurrent major depressive disorder. However, for step 1, examiners rarely like to include 5 or more SIG-E cap symptoms if they're trying to get you to think of grief, because they're usually going to have MDD as one of the distractors among the answer choices. So there will usually be less than 5 SIG-E cap symptoms, and the question will be focused around the loss of a loved one. Another key difference between MDD and grief is that someone with grief may want to be dead, but their thoughts of dying are centered on a yearning to be with the deceased. Whereas someone with MDD will be suicidal due to hopelessness and a feeling of inadequacy or worthlessness. Individuals with normal grief will begin to adapt to their loss and feel restored to normal life within 6 to 12 months of bereavement. The Kubler-Ross model of a normal grief reaction deals with 5 specific stages, and you can use the phrase, losing a loved one feels bad, to recall the 5 stages. They include bargaining, anger, acceptance, denial, and depression. These can occur in any order and are commonly accompanied by intense feelings such as waves of sadness, guilt, anger, leaden paralysis, and sporadic hallucinations involving the deceased. Complicated grief is similar to typical grief, but has more severe symptoms. As you can see, most of the ideas are similar to typical grief, they're just more severe. So yearning for the deceased, thoughts about the person who died, an urge to join the person who died, and depressive symptoms. Another key distinction is that complicated grief persists longer than 6 months, and it's associated with functional impairment. All right, let's review with the question. A 43-year-old woman presents to her physician due to insomnia. She states that she went through a divorce 3 weeks ago and has felt depressed since the event. She also finds herself feeling guilty about putting her children through this experience. She denies weight gain fatigue or suicidal ideation. She also continues to enjoy spending time with friends and reading books. Physical examination is normal. Laboratory results show a TSH level of 2.5, normal is 0.5 to 5, and a free T4 of 7, normal is 5 to 12. What is the most likely diagnosis? A, normal sadness, B, grief, C, complicated grief, D, hypothyroidism, or E, major depressive disorder. All right, from the question stem, we can see that this patient went through a divorce, and is now experiencing some depressive symptoms. She has insomnia, has felt depressed, and has felt guilty about putting her children through this experience. Also notice that this has been going on for 3 weeks. It's important to know that she denies weight gain, fatigue, or suicidal ideation. So collectively, this should make you think of normal sadness. The correct answer is A, normal sadness. B and C are incorrect because the question stem says nothing about the loss of a loved one. Remember, if we're dealing with grief or complicated grief, we're almost always talking about the loss of a loved one. D is incorrect because her TSH and free T4 levels are normal. Finally, E is incorrect because she only has 3 of the SIGI-CAP symptoms. Remember, 5 SIGI-CAP symptoms for 2 weeks is required to diagnose MDD. So E is incorrect. All right, now that we've covered MDD and some of the things that may present similar to MDD, let's return to the table and discuss other depressive disorders. The next disorder is MDD with psychotic features. This is exactly what it sounds like. The diagnostic criteria and features of this disorder are very similar to MDD. The only difference is that these patients will simultaneously be psychotic. So you can see that we've stated that the episode must last at least 2 consecutive weeks and that it must simultaneously occur with psychotic features. We'll discuss psychosis in a later lecture, but for now, just know that this is referring to a loss of contact with reality and is associated with hallucinations, delusions, and disorganized thought. The treatment for this disorder is similar to MDD. You use antidepressants, such as SSRIs for the depression, in combination with antipsychotics, which treats the psychosis. ECT may also be used, but pharmacotherapy is typically attempted first. Persistent depressive disorder, or dysthymia, is characterized by a pattern of depressive symptoms that don't quite reach the criteria for MDD. So they don't have 5 of the 9 SIGI-CAP symptoms. You can remember how to differentiate dysthymia from MDD with the phrase too sad for too long, because the number 2 is key to making the diagnosis. There must be at least 2 depressive symptoms, which must last for at least 2 years and not let up for more than 2 months at a time. So these patients will have a period of normal mood, but these cannot last longer than 2 months before they go back into a depressed mood. The treatment for dysthymia is similar to MDD and includes CBT plus or minus antidepressants. MDD with seasonal pattern deals with depressive symptoms that meet criteria for MDD, but only occur during a certain time of the year. So symptoms must be present for over 2 years, and the patient must have at least 2 episodes of MDD that have occurred during a certain season. So there's a seasonal pattern associated with it. This is usually in the fall or winter, and then their mood should be normal for the rest of the year. These patients also often have increased rates of certain symptoms like leaden paralysis. This is where the patient describes a type of fatigue where their arms and legs feel particularly heavy. They may also complain of hyperphagia and hypersomnia. This disorder often responds well to treatment, but if left untreated, often recurs the following year. So maintenance treatment is important for these patients to prevent depressive symptoms from reoccurring. Treatment methods include not only CBT and antidepressants, but also light therapy. So these patients literally have lights inside of their house that are used to treat this disorder. Depression with atypical features is basically MDD with an ability to feel happy when things go right. So there is some improvement with positive events. One unique feature of this disorder is that these patients experience interpersonal rejection sensitivity. In other words, they're overly sensitive to rejection and constantly look for evidence that others are rejecting them. We discussed that a key diagnostic feature of MDD is anhedonia, or an inability to feel pleasure. So this is one of the ways that these two disorders differ. Just like MDD with seasonal pattern, this disorder is also associated with atypical symptoms, including leaden paralysis, hyperphagia, and hypersomnia. The treatment for depression with atypical features is the same as MDD, with CBT and SSRIs as first-line therapy, but occasionally monoamine oxidase inhibitors are used. However, these have some pretty dangerous side effects, so they're much less commonly used today. All right, before we move on to the peripartum-related disorders, let's review with a quick question. A 33-year-old female presents to the office due to a prolonged feeling of sadness. She says she first noticed this feeling approximately 3 years ago. She also mentions that she always feels guilty about mistakes made from her past. She endorses periods of feeling happy, but these are typically short-lived and only last a few weeks at a time. What is the most likely diagnosis? Okay, hopefully from the question stem you notice that this patient has felt sad and guilty for the past 3 years. She also has had periods of feeling happy, but these only last a few weeks. This is describing dysthymia. From the table, recall that dysthymia is characterized by 2 or more MDD symptoms that last for 2 or more years, and that these patients can have periods of a normal mood, but that they cannot last longer than 2 months. So this is perfectly describing the patient from the question. All right, now let's move on to discuss peripartum mood disturbances, which are depressive disorders in women that are pregnant or have recently given birth. There are several risk factors associated with the peripartum mood disturbances, but the key one to remember is a history of mood disorders. Maternal postpartum blues is the most common peripartum mood disorder. It typically begins 2 to 3 days after delivery and resolves by day 10. It's characterized by overwhelming feelings of fatigue, sadness, insomnia, an inability to focus, and difficulty with day-to-day functioning. Suicidal ideation should not be present. Among the peripartum mood disturbances, this is the most common, with an incidence rate of 50 to 85%. The treatment is supportive, but follow-up is key to detecting new or recurrent depressive symptoms. Next is major depressive disorder with peripartum onset. This typically begins with the first month after delivery and lasts at least 2 weeks. Patients meet criteria for MDD, so they have over 2 weeks of at least 5 of the SIGI-CAP symptoms. You can distinguish this disorder from postpartum blues by the severity of the symptoms, the possible presence of suicidal ideation, and the fact that it does not resolve by day 10. The incidence rate is 10 to 15%, and the treatment is the same as MDD, with first-line therapy being CBT and SSRIs. Finally, let's discuss postpartum psychosis. This is a dangerous disorder that typically begins within 2 weeks after delivery and involves the presence of typical psychotic symptoms. Most notably, these include hallucinations, delusions, and homicidal or suicidal thoughts. These can be directed towards harming the baby or harming oneself. Risk factors for developing postpartum psychosis include stopping mood-stabilizing medication, a previous history of bipolar disorder or psychosis, a family history of postpartum psychosis, and this being their first child. This has the lowest incidence rate among the peripartum mood disturbances and is 0.1 to 0.2%. This is a medical emergency, and patients should be hospitalized and evaluated quickly. Antipsychotics are normally the first-line treatment and possibly a mood stabilizer if a history or symptoms of bipolar disorder or MDD are present. Lastly, electroconvulsive therapy is recommended for women resistant to antipsychotic medication or mood stabilizers. All right, let's wrap up this video with one more question. A 43-year-old woman comes to the office for a yearly checkup. She states that her daughter passed away in a car accident 5 months ago and is very sad about the incident. She has difficulty leaving the house, feels intense anger toward the person who hit her daughter with their car, cries often, and regularly thinks about her daughter longingly. At the end of the interview, she smiles as she shares what she loved most about her daughter. Which of the following is the most likely diagnosis? A. Complicated grief. B. Grief. C. Major depressive disorder. D. Normal sadness. E. Dysthymia. Or F. Depression with atypical features. Okay, hopefully from the question sent, you notice that this woman lost her daughter 5 months ago and is now experiencing some sadness. She has difficulty leaving the house, feels intense anger, cries, and thinks about her daughter regularly. This is consistent with grief, so the correct answer is B. Remember, if a question mentions the loss of a loved one, then you should immediately begin thinking about grief. A is wrong because her symptoms haven't lasted longer than 6 months, and they aren't so severe that they're causing functional impairment or depression. C is wrong because she only has a depressed mood and possibly some anhedonia because she has difficulty leaving the house. However, 2 out of 5 of the SIGI-CAP symptoms is not sufficient to make this diagnosis. D is wrong because the question stem states that she lost her daughter and these symptoms have been going on for over 5 months. Normal sadness would not cause any functional impairment and is unlikely in the setting of recently losing a loved one. E is wrong because this patient has only had symptoms for 5 months, not 2 years. Finally, F is wrong because this patient doesn't have rejection sensitivity or leaden paralysis, and she just lost a loved one, so grief fits better with this picture. So again, the correct answer is B, grief. And that should be everything you need to know about depression and the depressive-related disorders.